Today in the series of DocPlexus-Part interviews, we have Dr. Unnikrishnan with us, who was formerly a professor at Unnikrishnan Institute, Kochi, and now is the CEO at Children Diabetes Institute, Pune. So thank you so much for giving us your time. When the TSH levels are comparatively high, between 6 to 9, should thyroxine be administered immediately, or we should redo the tests?
I think if the TSH is slightly high, the usual TSH is about 0.4 to 4. If the TSH is more than 4, and usually in these cases the T3 and T4 are normal, that's a disease we call subclinical or mild hypothyroidism.
Okay.
Now there are some situations where you would like to treat. For example, if there is infertility, if there are irregular periods, if there is dyslipidemia, if there are neuropsychiatric symptoms, if there are any symptoms of hypothyroidism, if there is a goiter, if the anti-thyroid antibodies are positive, you would like to treat the patient. But let me also state that in these mild thyroid failure cases, which are called as subclinical hypothyroidism, there is really no emergency to treat these patients. You can always wait for some time. And you can wait for some time because there have been studies which have shown that, about 20% of these patients with mild subclinical hypothyroidism can spontaneously remit without any treatment over a period of 2 or 3 months.
Okay.
So if you have a strong reason or a symptom with the patient has which requires treatment, for example, in pregnancy we would like to treat immediately, or if the patient has infertility or depression or something like that where you need to start treatment. But other than that, in the routine patients where you're not sure, it's always good to repeat the test after 3 to 6 months, and if it is persistent, then you can treat with a small dose of thyroxine. And if there is a TSH level of more than 10, then generally you would like to treat the patient irrespective of whatever the condition is, because when the TSH is more than 10, that means the thyroid gland isn't producing much hormone and the thyroid gland has already failed. That one cutoff, so remember a TSH value of 10 is a number to remember beyond which you would necessarily have to treat with thyroxine. But between, say, as you mentioned, 6 to 9 or between between 4 to 10, I think that you can always wait and recheck, and then you can start treatment.
So what would be the relative criteria to stop or start the medicine for hypo and hyperthyroidism both?
I think in hypothyroidism, it's important to be very sure that the patient has primary hypothyroidism, because once you make sure that the patient has primary hypothyroidism and then you begin the treatment, it's likely that the treatment is going to be long term. Now, there are some clues which will tell you that you can reduce or stop the treatment. For example, in hypothyroidism, when you're giving thyroxine and the patient is actually starting to lose weight or getting tremors or getting palpitation or the heart rate is going up, that suggests that the thyroxine dose is a little high and you need to reduce it. And in that case, or if you see that despite giving a small dose of thyroxine, you find that the TSH is still suppressed, that means you can start reducing the dose of thyroxine. Sometimes when you're not sure, it is always okay to maybe reduce the dose by about 25%. For example, if the patient is on 100 mics of thyroxine, you can reduce it to 75, see if the TSH goes up, and then take a decision on treatment. In hyperthyroidism, it is a different case. It depends on the cause. For example, if it is Graves' disease, or the common cause of hyperthyroidism is Graves' disease, and you are treating with anti-thyroid drugs, usually after 1.5 years or 2 years, if the disease has not gone into remission, you would like to give radioactive iodine treatment or surgery for those patients. Sometimes if it's a toxic multinodular goiter, you will have to control the thyrotoxicosis with medicines and then take up the patient for surgery. So therefore, it's a very difficult decision to stop treatment in hyperthyroidism. But in hypothyroidism, some certain subtle clinical clues can tell you that this patient medicine can be reduced and stopped.
Sir, in the family history of a family having height retardedness, the height of a boy between 8 to 10 years of age can be increased by hormone replacement therapy. So are there any research done for the same for the girls between age 8 to 10 years of?
Well, I think if somebody comes with a short stature, whether it's a boy or a girl, we need to first evaluate for secondary causes of short stature. For example, is it hypothyroidism? Is it a vitamin D deficiency? Is it a growth hormone deficiency? Now, if there are no such deficiencies found and you think it is a familial short stature or an idiopathic short stature, yes, if you look at very strict criteria, you can treat with growth hormone. But remember, when you treat with growth hormone, you might be altering the natural history of the disease. Also, some of these children may actually have a potential to grow up height on their own, and you might be interfering with what the body's natural course is. So it has to be very clear that are you allowing the patient to grow on his or her own pattern, or are you going to interfere? To distinguish between these two strategies, it is always important to reassess the child after 6 months or a year, because you can see the growth velocity, the height change, the rate at which the puberty is progressing, and looking at all that, it is good to take a decision. And that is why these children who we call them, who are short by the growth curve, when you plot the growth of a child on a growth chart, when they are below the centiles, it is important for them to be evaluated as soon as possible, so that we have some time to see, how after 1 year or 6 months, what is the growth change, and then take a call. So the short answer to your question is yes, there are treatments available for both boys and girls with short stature. They have to be selectively chosen and judiciously prescribed.
Okay. Sir, most of the doctors have a perception that hypothyroidism leads to obesity. So, and it also hampers loss of weight. What are your opinions on this?
I think it's a very valid point, and if you notice the indications of you asked me a question about TSH 6 to 9, would you treat with thyroxine? I purposely didn't emphasize obesity.
Okay.
And that's because hypothyroidism leads to weight gain. So many patients feel that it is the hypothyroidism that is causing the weight gain. But it's important to note that mild hypothyroidism, like I talked about subclinical hypothyroidism, where the T3, T4 are normal and only the TSH is high, that doesn't lead to much weight gain. Maybe there may be a weight gain of 1 or 2 kilos or 3 kilos. And that gain is due to both fluid and fat accumulation. So by treating hypothyroidism, remember, you can get maybe a 2 or 3 kilo weight loss only. Of course, there is an occasional patient who may lose 8 or 10 kilos. But I think it's important for our viewers to also realize that when you prescribe a drug for hypothyroidism, the patient should not have an excessive expectation of weight loss. That probably doesn't happen. The weight gain due to hypothyroidism is mild, and the weight loss that accrues from the treatment of hypothyroidism is also mild. Okay. So it's only a mild weight change.
Okay. Sir, administration of insulin has always been complex as well as have multiple regimens. So are there any practical or significant methods of administration of insulin in order to control the blood glucose?
Well, I think insulin has to be used when the HbA1c is going up, despite oral tablets, 2 oral tablets or more if are required, then you would think of insulin. Unfortunately, insulin cannot be drunk or eaten because it gets digested, so you have to inject it. There's no other way, as we doctors all know. But I think there are now very simple ways of treating patients with insulin. For example, if the blood sugar patient is on oral tablets and the sugar has just started going up, and if the fasting sugar is just a touch high, you want to keep the fasting below 110. But let's say the fasting is about 130, 140 and the postprandial is not that high, it's about 170, 180 only. Then I think it's a right patient to be given basal insulin. A basal insulin is a single injection of insulin that lasts for 24 hours. Remember, in a non-diabetic person, you have insulin throughout the day to control glucose. Each time you eat food, you require a little bit insulin to cover the glucose from each meal. So the minimum insulin that is required throughout the day is called the basal insulin. And therefore, when the HbA1c is just started to rise and the fasting is just a little high, a small dose of basal insulin, maybe 10 units at bedtime, will be enough as an add-on to tablets. You have to continue tablets to control the sugar. But majority of the times in India, what happens is patients come for insulin therapy when the blood sugar is already high. Fasting is already 200. Postprandial is already 300. In that case, there are 2 regimens which we can use. One is called a simple premix regimen, which means 2 times a day, mixture of the short-acting and the intermediate-acting. And the premix insulin, the dose is about 0.5 units per kilogram per day, which means if the patient is 60 kilos, then the dose would be 0.5 into 60, which is 30 units a day. Now you give 2/3 in the morning and 1/3 in the evening of the premix insulin. Usually it's a 30-70 premix insulin. And why 2/3 in the morning before breakfast? Because there are 2 meals after that. There is breakfast and lunch. And 1/3 before dinner because there was only 1 meal after that. So you start with that, then adjust the dose to reach control. So if it's a 60 kilogram person, you would require about 30 units of insulin. 2/3 in the morning means 20 units in the morning and 10 units at night. So that's a premix regimen. But sometimes the sugar is very high, 400, 500. You may have to give what is called the basal bolus regimen, which is what I said, one basal insulin to give for 24 hours and one short acting with each meal. So 4 injections, 1 basal and 3 boluses with each meal. So these are the 3 insulin regimens. Basal only, premix, which means 2 injections, and basal bolus, which means 4 injections. Now, which patient to choose is an art as well as a science, but there are good guidelines you can find on the internet how to choose these patients for the appropriate insulin regimen. Remember, if the blood fasting is very high, a basal insulin will help. If the fasting and postprandial are moderately high, a premix would help. And if the fasting and postprandial are very high, you will need to give the 4 injection basal bolus, which is the ideal way to give insulin.
So theoretically, there is a difference between fasting and posting of a person who is aged 50 years and below and 50 years and above. So what should be the cutoff range for the blood glucose level?
I think if somebody's blood sugar, the fasting is more than 126, we call that person to have diabetes. And after glucose load, if the value is more than 200, we say that there is diabetes. Now, as the age advances, diabetes is more and more common. But you cannot say that for a person at this level is diabetic at this age, but at this age he is not diabetic or she is not diabetic. I think the level of control is the same. However, in very old persons with diabetes of 20 or 30 years with advanced cardiovascular disease, trying to control the sugars very, very aggressively is not a good idea because it can lead to hypoglycemia, which can be dangerous for elderly people. But a very young person who's diabetic recently, a 30-year-old gentleman diabetic for 2 years, I think that's a good person to control blood sugars tightly from day one because hypoglycemia, he is or she is more likely to be aware of hypoglycemia. And you also asked me for the difference between fasting and postprandial. Fasting blood glucose is thought to be an indicator of beta cell dysfunction. The pancreas produces insulin because a pancreatic cell called the beta cell produces insulin. So beta cell dysfunction results in a high fasting glucose. The postprandial high glucose in diabetic is a combination of both beta cell dysfunction and insulin resistance. Of course, these are just theories and it's very difficult to rigidly compartmentalize these two groups. But in general, you have to control the fasting and the postprandial because studies have shown that controlling both is important to limit the onset and progression of diabetes-related complications.
Sir, the SGLT2RB drugs that are very useful in treating obesity, obese diabetic patients basically. And there are also adverse drug reactions like acidosis. So should we inhibit this molecule for treatment of obesity diabetic patient?
I think the SGLT2 inhibitors are excellent new drugs for management of diabetes. They push out glucose into the urine and therefore they bring down the blood sugar at all stages of diabetes and on people of all medicines. On any kind of medicine, you can add this drug on, including you can add it onto insulin therapy. Now, because it pushes out glucose into the urine, there is a slightly higher risk of urinary tract infection because the glucose-rich urine is a culture medium for bacteria to grow. So therefore, you have more urinary tract infection and you have genital mycotic infections, and these are very common in women actually when you look at the number. But overall, the number of these genital mycotic infections and urinary tract infection is not much. But you have to be careful, it's a new drug. You mentioned weight loss. The weight loss with these drugs is only moderate, about 3 or 4 kilos. But definitely 3 or 4 kilos of weight loss is good. And they also have a beneficial effect on blood pressure. So they reduce blood sugar and have a lot of some benefits and some side effects. Yes, there was a recent FDA alert on acidosis, but this was based on a search of the FDA database, and there are millions of people taking these drugs across the world, and this group of SGLT2 inhibitors, dapagliflozin and canagliflozin, has been studied in large trials. So acidosis was found in about, if I remember right, the FDA alert said about 20 patients had acidosis and there was a risk of hospitalization. Important to remember that do not use these drugs in patients with severe hyperglycemia and osmotic symptoms. By osmotic symptoms, I mean excess thirst, excess urine, and polyuria, polydipsia, polyuria. Somebody with that kind of a high sugar and osmotic symptoms, maybe I wouldn't use this drug. In a type 1 diabetic patient who is at risk of ketoacidosis, I wouldn't use this drug. But by and large, these are good drugs because they are helping us manage the blood sugar, helping the patient to lose some weight, and also helping to control the blood pressure a little bit. So they are good drugs to use. Let us use them judiciously. Let us explain the benefits and the risks of these therapies to the patient. Particularly, patients should drink a lot of water so that they don't get urinary tract infection. And if they get burning pain while passing urine or micturition, they should report to the doctor. I think these are excellent drugs because they are one more oral drug for management of diabetes and have some weight benefits as well. Let us use them judiciously and carefully.
Sir, you have been using DocPlexus, and what are your opinions for doctors like DocPlexus being a technology platform?
I think the DocPlexus as a technology platform has been quite welcome because we as doctors don't have our own forum to interact and discuss our ideas and our thoughts, to discuss cases, to discuss the latest in science, to discuss problems which are worrying doctors in patient care and in the personal life of how doctors manage their busy clinical lives with their personal lives. So I think a lot of these issues I'm seeing are covered in DocPlexus, and I think it seems to be a forum which is genuinely helping doctors not only in their career but also in balancing, doing their work-life balance as well. I think it's a very good and noble idea to develop a platform like DocPlexus, because when doctors are able to interact with each other, understand and empathize with each other's problems, and when they learn more through a knowledge sharing activity, I think it will have a beneficial impact on the lives of millions of patients in our country. And India is a country where we need to take care of millions of patients with any disease. If you look at diabetes, more than 64 million or more people have diabetes. And therefore, I think such platforms which help us to manage patients better are always welcome. I wish the DocPlexus group all the best and continue to do the good work to help the medical fraternity and improve the lives of millions.
Thank you so much, sir. And on behalf of DocPlexus team, I would definitely like to thank you for your time and your inputs. I'm very sure that the video would be very informative for the doctors on DocPlexus. Thank you so much, sir.
Thank you.